Welcome back to the Deep Dive. Today, we are taking on a source that is, well, it's fundamental, it's massive, and it's pretty much indispensable. The 28th edition of Baily and Love's Surgery.
And we're not just flipping through pages.
No, not at all. We are performing what you might call an intellectual arthroscopy on one very specific, very dense, and often challenging area. Chapter 38, the upper limb.
That's right. And for our listeners, especially those of you navigating surgical training right now, this deep dive is really custom tailored. Our mission here is interpretation, not just recitation.
Exactly.
Think of this as us translating that dense textbook language into functional, clinical decision points. We really want to provide some clear conceptual anchors and a kind of ready reckoner for revision.
We want to give you the context, the why behind the facts, turning pure information into something memorable, something that sticks. But we have to stress this.
Oh, absolutely.
This analysis is a map, a guide, but you absolutely must read the book itself for that comprehensive, deep understanding.
Yes. The upper limb is it's a study in extraordinary mechanical complexity. It's defined by this massive range of mobility, and then at the other end, this ability to achieve incredibly precise function in the hand.
And from an orthopedic perspective, you can't look at it in pieces.
You really can't. It has to be viewed as a totally integrated system. We're talking about structures that are so intricately linked, where a biomechanical failure at the most proximal point, the shoulder, can lead to functional disaster all the way down at the wrist.
And vice versa. So we're going to tackle this systematically. We'll start with the magnificent complexity of the shoulder girdle, then analyze the common failures of the rotator cuff.
After that, we'll discuss the challenging landscape of arthritis and instability, pivot to the unique hinge and pivot mechanics of the elbow.
And then we'll finish with the really critical, often unforgiving realm of hand and wrist pathology. That includes those surgical emergencies that demand immediate action. So let's begin where the arm begins, at the shoulder.
The shoulder girdle.
So when we talk about the shoulder, I think our first anchor concept has to be that it's not just one joint, it's really a three-part orchestra.
That's a great way to put it. An orchestra of the clavicle, the scapula, and the humerus. We all tend to focus on the glenohumeral joint, the ball and socket, but that completely ignores the foundation it's built on.
And if we dig into that foundation, there's a crucial anatomical nugget in there, isn't there?
There is. The sternoclavicular joint. It might seem a bit insignificant, but it is the only true synovial joint that provides a direct bony connection between the entire upper limb and the axial skeleton, your spine and chest wall.
The whole arm hinges on that one single point of contact.
The whole thing. That makes the clavicle this absolutely critical strut transmitting all the force. And this leads directly into the core principle of movement here, the scapulothoracic rhythm.
Right, so we get 180 degrees of elevation, but the textbook makes it crystal clear that pure glenohumeral rotation is actually just a fraction of that total arc.
It's a beautifully coordinated ballet. Roughly 50 degrees of that 180 comes from the scapula just rotating across the back of the thorax.
Okay.
Then another 30 to 60 degrees involves the clavicle elevating and rotating slightly at that sternoclavicular joint we mentioned. The rest of it, the remainder, that's pure glenohumeral rotation.
So if that rhythm breaks down,
yeah,
say because of muscle weakness or scarring,
then you lose the full range of motion. Even if the glenohumeral joint itself is perfectly healthy, it all has to work together.
And the book highlights one movement as absolutely non-negotiable for achieving that full range, the external rotation of the humerus. Why is that so critical?
It all comes down to clearance. It's a space issue. As the arm lifts, those crucial structures attached to the greater tuberosity, we're talking mainly about the rotator cuff tendons, the supraspinatus insertion, they need space to pass.
So if the humerus doesn't externally rotate,
it's a hard stop. That greater tuberosity slams directly into the undersurface of the acromion and the coracoacromial ligament. This action, or I guess the lack of it, it prevents full elevation. It limits you to about 90 degrees, and as we'll get into, it is the core mechanism of impingement.
Okay, so that gives us the ideal anatomy, the perfect ballet. Let's look at what happens when development hits a snag. Let's focus on congenital abnormalities, and the most common one is Sprengel's shoulder.
Right.
What's the anchor memory for this one?
The anchor is failed descent. The scapula, embryologically, develops high up near the neck, and then it's supposed to descend during development. In Sprengel's, it just gets stuck high.
And what does that look like clinically?
You see a high, small, and rotated scapula. Functionally, it severely restricts abduction. The child just can't lift their arm out to the side properly.
And we need to know the specific anatomical reason for that restriction, don't we?
We do. It's often tethered to the cervical spine by what's known as the omovertebral body. This can be a fibrous band or cartilaginous or even a solid bar of bone. It acts like a rigid anchor, preventing any normal scapular rotation and descent.
And there are associated issues to look for.
Always. You have to look for associated anomalies, especially in the cervical and thoracic vertebrae. Things like Klippel-Feil syndrome, which is the congenital fusion of cervical vertebrae. So these patients have compromised neck movement on top of their shoulder problems.
Then there's this other oddity, pseudarthrosis of the clavicle. Why is this such a major clinical trap?
Because it's congenital, but it perfectly mimics a non-union, a fracture that just failed to heal. This often leads to a sort of spurious history of birth trauma or a minor fall that isn't the real cause.
So the clinical significance for a trainee is massive.
Profound. If you see a non-union in the middle third of the clavicle, especially without a clear history of high-energy trauma, you have to suspect pseudarthrosis. The book explicitly warns that attempting to plate it or bone graft it is notoriously unsuccessful. You have to recognize it for what it is to avoid a futile surgery.
Okay, let's move on to acquired abnormalities. The text really emphasizes the absolute necessity of a thorough history. What is the #1 priority question in a shoulder clinic before you even touch the patient?
Always ask about the neck.
Trust me.
Always.
Yeah.
Pain radiating into the upper limb from cervical nerve root irritation, cervical radiculopathy, can perfectly mimic intrinsic shoulder pathology.
Right.
So getting the age, occupation, hand dominance, that all gives context. But ruling out the cervical spine as the primary source of the pain is absolutely paramount.
And is there a good clinical differentiator, a clue to tell them apart?
Yes. Localization. If the patient can take one finger and point to the exact spot in the shoulder that hurts, say, the posterior acromion or the anterior capsule, it's highly suggestive of local intrinsic shoulder pathology.
And referred pain.
Referred neck pain rarely has that sharp pinpoint localization. It tends to be more diffuse, or it follows a recognizable dermatomal pattern down the arm.
Let's move to the physical examination. We need to differentiate between pathology that's related to pain and pathology that's more about mechanical failure. Let's start with tests for impingement.
Okay, so impingement tests, like the classic Hawkins test, are fundamentally pain provocation tests. You are deliberately trying to force the cuff up against the acromial undersurface.
How does that work?
You bring the arm up to 90 degrees of forward flexion, and then you forcefully internally rotate it. This maneuver minimizes the space under the acromion. If the patient cries out in pain, that's a positive test. You're confirming the location of the inflammation.
Okay, so that's for impingement. Now, what about for tears?
For tears, the target is different. It's weakness. We are testing the functional motor integrity of the tendon. The empty can test for the supraspinatus is an old standard.
You're putting the muscle under a specific stress.
Exactly. You position the arms in 90 degrees of abduction and 30 degrees of forward flexion with the thumb pointing down like you're emptying a can. Then you ask the patient to resist your downward pressure. If they are truly weak, regardless of the pain, you have to suspect a tear.
And how do you tell if the weakness is from pain or a real tear?
That's the critical point. If they're weak because of pain, they're guarding, and the weakness is often inconsistent. If it's a real mechanical tear, the weakness is profound and it's consistent every time you test it.
And for our third category, instability.
For that, we use apprehension tests. These are checking the structural integrity of the labrum and the capsule. For anterior instability, you put the arm into the position of injury abduction and forced external rotation.
And what's the patient's reaction?
It's often this look of impending doom. They will actively guard, they'll pull back, or they'll tell you, stop, it feels like it's going to pop out again. That's apprehension.
Imaging is next. Now, x-rays might not show the soft tissue problems, but they are crucial for bone anatomy. What are the 3 non-negotiable things an x-ray can show in a painful shoulder?
Okay, 3 things. First, the status of the subacromial space. If that space is significantly reduced, it's a strong indicator of superior migration of the humeral head, often caused by a massive, full-thickness rotator cuff tear.
Okay, number 1 is space.
Number 2 is the presence of bony spurs, especially an acromial spur. And number 3 is the acromial morphology, the actual shape of the acromion.
Let's talk about that morphology. The textbook highlights 3 types: flat, curved, and hooked. What's the clinical takeaway here?
The hooked acromion is the key one. It is strongly associated with higher rates of impingement and cuff tears because it physically reduces that already confined subacromial space.
It's a tighter squeeze.
A much tighter squeeze. Now, there is a nuance here, which the text mentions. Is the hook shape congenital, or is it more likely an acquired finding?
You mean it develops over time?
Exactly. It might be secondary to calcification of the coracoacromial ligament insertion, which is a consequence of the ongoing degenerative process rather than the original cause of it.
So when we need definitive soft tissue detail, we have to graduate from X-rays. What's the hierarchy of tools?
Ultrasound is great. It's rapid, it's dynamic, you can see the cuff move, but it is highly operator dependent. You need a good sonographer. MRI gives you superb detail on the cuff muscles.
What can you see on the MRI?
You can check for fatty atrophy, which is critical because it dictates whether a tear is even repairable. And you get a great look at the tendons themselves. But if you are specifically chasing a subtle labral tear or a capsular detachment, which is common in instability,
Then you need something more.
then MR arthrography is superior. You inject contrast into the joint, and it highlights these structures far better than a standard MRI.
Before we leave this section, let's just circle back to the local anesthetic injection, the positive nearest test. You said it's a powerful differentiator.
It really provides clarity. If we inject anesthetic into that subacromial bursa and the patient's painful arc, the hallmark of impingement, completely vanishes, we have definitively located the pain generator. It's that bursatin interface.
Okay, so let's pause for a check-in question here. This is to really solidify this crucial concept for you, our listener. Imagine a 45-year-old carpenter comes in. He has agonizing pain when reaching overhead.
Okay.
On examination, you reproduce that painful arc. But then, after a local anesthetic injection, he can raise his arm fully overhead, totally pain-free, but he still shows significant weakness when you ask him to hold his arm up against your resistance. What specific conclusion should you draw, and what investigation is now mandatory?
That's a great scenario. So the fact that he can now move his arm fully and it's pain-free, that tells you the pain was caused by impingement and bursitis. Simple as that.
But the weakness is still there.
But the persistence of true weakness, despite the pain being gone, tells you that the weakness is mechanical. That is the definitive clinical sign of a significant full-thickness rotator cuff tear.
So what's the next step?
The next mandatory investigation is an MRI or an ultrasound to confirm the size and the retractability of that tear. Because surgery is now very likely on the cards, the injection basically removed the pain barrier, and in doing so, it revealed the mechanical failure that was hiding underneath.
That distinction, pain versus weakness, is the perfect bridge to our next section, the rotator cuff itself. Let's anchor this with the concept of the vicious cycle of impingement.
Okay, so the cycle really originates in that anatomically constrained space we talked about earlier, the subacromial space. The four rotator cuff muscles, supraspinatus, infraspinatus, teres minor, subscapularis, the S-lights muscles, they're the dynamic stabilizers, and they're all operating in this very tight corridor.
And there's a biological flaw here too, right? The blood supply is quite fragile.
Absolutely. The supraspinatus tendon in particular has what's called a critical zone of hypovascularity. It's an area with poor blood supply right near its insertion into the greater tuberosity.
So what happens when the arm is active?
When the arm is active, the vessels that enter from the muscle belly or from the bone get compressed as the tendon wraps around the humeral head. This restricted blood flow really limits its ability to repair minor damage, making it highly susceptible to progressive, age-related tissue breakdown. We call that tendinosis.
So we have a confined space and vulnerable tissue. How does a simple strain or a bit of inflammation escalate into a painful chronic condition?
Well, a small injury or just chronic overuse causes inflammation and swelling in that hypovascular tissue or in the bursa that sits on top of it.
And now the already tight clearance is gone.
It's gone. The swollen tendon or bursa gets repeatedly ground and abraded against the unforgiving undersurface of the acromion, often against a bony spur. That is the impingement.
And that grinding just causes more problems.
Exactly. This mechanical grinding causes more irritation, more inflammation, and more swelling. It creates a self-perpetuating vicious cycle of pain and progressive degeneration.
The patient experiences this as the painful arc. Why that specific range? 60 to 120 degrees.
Because that is the specific arc of elevation where that inflamed, swollen supraspinatus segment is forced to pass directly under the anterior acromial margin. Outside of that range, at rest or when the arm is fully elevated above 120 degrees and has cleared the acromion, the pain is often completely absent. It's a highly diagnostic clinical sign.
In treatment, then, the first goal is just to interrupt that cycle.
Yes. The non-operative approach uses a targeted steroid injection right into the subacromial bursa. The corticosteroid is a potent anti-inflammatory. It's designed to rapidly deflate the swelling, which then allows the tendon to glide freely again.
And once the pain is under control.
Once the pain is controlled, the absolute key is aggressive physiotherapy. You have to retrain that scapulothoracic rhythm and restore normal cuff motor patterns to prevent the cycle from just starting all over again.
Okay, so if non-operative treatment fails after, say, a committed trial of several months, surgery is on the table. Arthroscopic subacromial decompression. What exactly is being removed surgically?
You're removing the bony obstruction, so that's the anterior hooked part of the acromion, what we call an acromioplasty, and often the thickened coracomial ligament is released as well. The whole goal is to maximize the clearance space for the cuff.
But the textbook contains a really crucial caveat about the long-term effectiveness of this operation.
It does, and it's critical. Despite the good short-term pain relief it provides, the current evidence shows no difference in long-term prognosis between surgical decompression and a good non-operative treatment program.
So it's a symptomatic procedure.
It is. It does not reliably prevent the underlying tendinosis from progressing into a full-thickness tear down the line.
Let's pivot now to rotator cuff tears themselves. These are common, especially in older adults, because of that same chronic poor blood supply and thinning of the tendon. Where do they usually start?
They almost always start anterolaterally in the supraspinatus tendon. That's the most vulnerable area. And then they tend to propagate posteriorly.
And what happens to the tendon over time?
Over time, the constant pull of the remaining intact muscle belly causes the torn tendon ends to retract medially, pulling away from the bone. This leaves a large, bare, non-functional patch of bone, the greater tuberosity.
We established that the defining feature of a large tear is mechanical weakness. Can you talk us through the clinical presentation in detail?
Sure. When the patient tries to lift their arm to abduct it, they lack that stable fulcrum that the cuff normally provides by holding the humeral head centered on the glenoid.
So the deltoid takes over, but it can't do the job alone.
Exactly. The powerful deltoid fires, but all it can do is pull the humeral head straight up. This results in a visible, severe compensatory shoulder hunching or shrugging. Active abduction is severely limited, maybe only to 60 degrees. It's a very characteristic sign.
Regarding treatment, what are the fundamental limitations here?
The main limitations are biology and time. These tears do not heal on their own. Surgical repair is best for younger patients and for acute traumatic tears, but the recovery is very prolonged.
How long are we talking?
We're talking 3 to 6 months of restricted activity for that repair to properly integrate and heal. If a patient can't commit to that long rest and rehabilitation period, the surgical repair is probably doomed to fail.
What happens when the cuff tear is massive, chronically retracted, and the MRI shows signs of fatty atrophy, the muscle turning to fat?
That's the irreparable tear. And at that point, we move from repair to salvage. The options include things like tendon transfers, but the most important modern solution is the reverse polarity, total shoulder arthroplasty, or RTSA.
The RTSA is a fascinating solution. Instead of putting the ball in the humerus and the socket on the glenoid like in an anatomical replacement, you literally reverse it. The ball goes on the scapula and the socket goes on the humerus. Why does this switch suddenly make a non-functional shoulder functional again?
It's pure biomechanical genius. By reversing the polarity, you shift the center of rotation of the joint medially and inferiorly. This shift dramatically increases the lever arm for the deltoid muscle.
So it makes the deltoid more powerful.
Massively more powerful and more efficient. The deltoid, which was previously ineffective because the cuff wasn't centering the humeral head, now becomes the primary engine for elevation. It requires no functional rotator cuff, and it provides reliable pain relief and often greatly improved function, especially in the setting of cuff tear arthropathy.
Let's run that fictional case study again, but this time focusing on the RTSA decision. Mr. Jones, our 75-year-old gardener, has that persistent weakness after his injection. If his condition progresses to cuff tear arthropathy, why is the RTSA mandatory?
The whole clinical scenario just screams massive irreparable tear. If this progresses to arthritis, what we call cuff tear arthropathy, an anatomical shoulder replacement will fail instantly.
Why?
Because the humeral head will immediately sublux superiorly. It'll ride up because there's no cuff to depress it and stabilize it. So the RTSA is mandatory because it's the only design that mechanically compensates for that irreversible loss of the rotator cuff's function. It uses the deltoid to pull the arm up, completely circumventing the failed cuff.
Next, let's tackle two very painful conditions that dramatically restrict movement but aren't primarily defined by acute trauma: frozen shoulder and calcific tendinitis. Let's start with the frustratingly common frozen shoulder, or adhesive capsulitis.
Okay. The anchor here is its natural course and its systemic associations. It's idiopathic, it typically hits females in their fifth decade, and the textbook strongly links it to diabetes, thyroid, and cardiac disease.
And for the patient, counseling is crucial, isn't it? Because the natural history is so prolonged.
Absolutely. It does resolve spontaneously, but it is not a quick fix. The standard course is 1 to 2 years and often significantly longer with more severe stiffness in patients who have diabetes. This slow, predictable course is defined by 3 phases: the painful phase, then the stiffening or frozen phase, and finally, the thawing phase.
What is the single clinical finding that really anchors the diagnosis and distinguishes it from, say, a tear or from osteoarthritis?
It is the global loss of both active and passive movement. The patient can't lift their arm, and crucially, you cannot move their arm for them. It's blocked. And the absolute pathognomonic sign is the severe loss of passive external rotation.
So you check for that, and you get a normal x-ray to rule out arthritis.
And you have your diagnosis: frozen shoulder.
Treatment depends heavily on which phase the patient is in.
It does. In the early painful phase, aggressive pain management is key: NSAIDs, simple analgesics. Once it moves into the stiffening phase, injections can really help. We use steroid injections, but also something called distension injections.
What's that?
That's where a large volume, maybe 20, 30 millirals of saline and local anesthetic is injected directly into the joint capsule. The procedure mechanically stretches the shrunken fibrotic capsule, which temporarily improves the range of motion and allows the patient to engage in effective physiotherapy.
And when do we escalate to surgery?
When the prolonged stiffness profoundly affects daily life, usually after 6 to 12 months of failed non-operative treatment, we might consider a manipulation under anesthesia, or MUA, which forcefully ruptures the adhesions.
Which sounds quite aggressive.
It is. Or an arthroscopic capsular release, where the surgeon uses electrocautery to systematically cut the scarred capsule. Both procedures carry risks, but they can significantly accelerate the thawing process.
Okay, let's contrast that now with calcific tendinitis.
This involves the deposition of calcium salts, usually hydroxyapatite, most commonly in the supraspinatus tendon. It's a spectrum. Often it's just an incidental finding on an X-ray. But when it's acute, the pain is agonizing. The source calls it florid. And on X-ray, you see these dense, opaque calcium lesions.
So if both conditions cause severe pain and restrict movement, how can we confidently differentiate acute calcific tendinitis from an acute frozen shoulder?
The clinical anchor is often external rotation. While it's severely painful, external rotation is usually preserved, or at least less glottally restricted, in calcific tendinitis than that really definitive hard block you see in adhesive capsulitis. Also, the pain in calcific tendinitis is often much more sudden in onset and more intense.
And the treatment for these calcium deposits?
It's often self-limiting. The body may spontaneously resorb the calcium. Symptomatic treatment focuses on anti-inflammatories and targeted injections. A key procedure is barbotage.
Barbotage.
That's where the deposits are located, either radiographically or with ultrasound, and then they're punctured, aspirated, and washed out or needled with saline and local anesthetic, followed by a steroid injection. Surgery, like excision or decompression, is really reserved for the small minority of cases that are truly resistant to everything else.
We move now to joint destruction. Let's start with rheumatoid arthritis.
Yeah.
How does RA specifically compromise the shoulder joint?
Well, RA is a systemic destruction driven by the synovial membrane. This leads to the classic findings: severe osteoporosis, which makes surgical fixation very difficult, destruction of the articular cartilage, and the formation of this destructive tissue we call PEM mass.
And in the shoulder?
Crucially, in the shoulder, the inflammatory process frequently leads to attenuation and tearing of the rotator cuff tendons very early in the disease process.
That immediately complicates any surgical planning, doesn't it?
Yeah.
If the bone is poor and the cuff is damaged, a standard replacement is pretty much a non-starter.
Precisely. While early on, treatment might involve an arthroscopic synovectomy, just removing the inflamed joint lining, modern biological therapies have really superseded this for disease control. When replacement is eventually needed, you encounter that complex RA triad: poor bone stock, severe glenoid wear, and a very high likelihood of a deficient rotator cuff.
So if the cuff is damaged, as it is in most advanced RA shoulders, which arthroplasty do we choose?
We circle right back to the reverse shoulder replacement, the RTSA. Since an anatomical replacement absolutely relies on an intact cuff for stability, the reverse design is usually the preferred option, particularly for pain relief, even when you have poor bone quality.
And what about function?
Functionally, the ability of the RTSA to improve the range of movement in RA patients is often a bonus, but the primary target is really pain management.
Now let's talk about osteoarthritis. The text outlines three key etiologies: primary OA, secondary or post-traumatic OA, and the end-stage result of massive tears cuff arthropathy.
Cuff arthropathy is the critical one for a trainee to recognize on an X-ray. It's that superior migration of the humeral head. It's riding high because the cuff is gone, and eventually just grinds away the undersurface of the acromine and the superior part of the glenoid.
This distinct pathology defines the arthroplasty decision tree. Let's break down the surgical options based on the status of the cuff.
Okay, if conservative treatment fails, the decision really hinges on the rotator cuff and the glenoid. Option 1, anatomical total shoulder replacement.
The ideal scenario.
It is. It provides the best pain relief and the most natural range of motion. But it is absolutely contraindicated if the cuff is deficient. You need a functioning cuff to dynamically stabilize the joint and prevent that superior subluxation.
Okay, option 2.
Hemiarthroplasty. That's replacement of only the humeral head. This is used in two main scenarios. First, for young, active patients who still have preserved glenoid cartilage, though the pain relief is less reliable than a total.
And a second.
And second, it's often an option when the rotator cuff is deficient, but the glenoid wear is minimal. But again, the outcomes regarding pain relief are quite unpredictable compared to a total.
And option 3 is our salvage.
Option 3 is the reverse polarity total shoulder arthroplasty. As we detailed, this is the mandated solution for cuff arthropathy and any other condition where the rotator cuff is irreparably deficient. It sacrifices anatomical fidelity for mechanical stability and deltoid power.
Let's discuss the ultimate salvage: arthrodesis, or shoulder fusion. Why on earth would a surgeon choose to fuse the shoulder, losing all glenohumeral motion?
Fusion is really reserved for patients where arthroplasty is just impossible. So, severe infection, a profound neurological flail, shoulder like a C5 brachial plexus injury, or complex tumor resections. It's a trade-off. You sacrifice mobility for a strong, stable, pain-free platform.
What must be functional for a patient to actually benefit from a fused shoulder?
They absolutely must have good scapulothoracic control. Since the glenohumeral joint is rigid, all movement now relies entirely on that scapulothoracic joint, that 50 degrees of rotation we mentioned at the very beginning.
So if the muscles controlling the scapula are weak,
The fused shoulder is useless, but if they're strong, the trapezius, the serratus anterior, the patient can achieve surprising functional movement, often enough to feed themselves and perform essential tasks.
finally for the shoulder, let's talk about that common pain generator that sits just externally: acromioclavicular joint arthritis.
Extremely common and often just an incidental finding. When it is symptomatic, the pain is activity-related, localized directly over the ACJ, and it's typically worst in the last 20 to 30 degrees of elevation or when reaching across the chest.
Because those movements compress the joint.
Exactly, and the injection is key here too. An intra-articular steroid injection is often both diagnostic, if the pain vanishes, and therapeutic. If symptoms persist, the definitive surgical solution is the excision of the lateral 0.5 to 1 centimeters of the clavicle. This simple excision decompresses the joint and provides reliable long-term pain relief.
Let's address instability, but first a quick look at a common and often dramatic site: the rupture of the long head of biceps.
This typically affects the degenerative tendon in older adults, and it's often linked to chronic impingement or a nearby rotator cuff tear. The history is dramatic, a sensation of something giving way, sometimes followed by relief if the patient previously had painful biceps tendinitis.
The visual is the giveaway, though.
It is. The classic Popeye sign. You see this visible bulge of the contracted biceps muscle belly when the elbow is flexed. The key learning point for the trainee is the functional outcome. Power loss is actually slight, mainly in supination and flexion, and it usually recovers very well because the short head of the biceps is still intact.
So surgery is rarely needed.
Surgery like a tenodesis or tenotomy is almost always a cosmetic procedure, not a functional necessity.
Now, to the complex issue of glenohumeral instability, the text classification is critical here, isn't it? Differentiating between three types based on the cause and behavior.
Yes, this framework dictates the treatment. We differentiate. 1. Traumatic. There was a defining event that caused unidirectional instability, usually anterior. This is a mechanical problem, and surgical repair is usually successful.
Okay. Tab 2.
2 is atraumatic. This is multidirectional instability, often painful, involuntary, and often linked to generalized laxity. Treatment here starts with intensive rehabilitation.
And the third type.
Habitual. This is voluntary, often painless. It's the party trick dislocator. This is a learned behavioral pattern.
Okay, focusing on the most common recurrent traumatic anterior instability. It typically happens in young, active patients. What clinical sign confirms this mechanical instability?
The apprehension test. Forcing the arm into that at-risk position of abduction and external rotation elicits protective guarding and that subjective feeling of imminent redislocation.
And what are the 2 named lesions we have to find on imaging that confirm the pathology of a traumatic dislocation?
First, the Bankart lesion. That's the detachment of the antero-inferior labrum and capsule from the glenoid rim. If a piece of the glenoid bone breaks off with it, that's a bony Bankart, which makes things much worse.
And the second lesion?
Second is the Hill-Sachs lesion. That's an impaction fracture on the posterior aspect of the humeral head, where the soft bone was slammed against the hard anterior glenoid rim during the initial dislocation.
And how do those lesions guide the surgical treatment?
For a simple soft tissue Bankart, an arthroscopic repair, just fixing the labrum back to the glenoid often works. But if there's significant bone loss, a large bony Bankart or a large engaging Hill-Sachs lesion, a simple soft tissue repair will fail.
So you have to address the bone loss.
You have to restore the bone stock,
Right.
often using a procedure like the Latarjet, where a piece of bone from the coracoid process is transferred to the anterior glenoid rim. The technical takeaway is that bone loss dictates the need for a bony procedure.
Let's discuss the really challenging one, posterior dislocation. Why is this so often the misdiagnosis anchor?
Because it's rare, only 2–4% of all dislocations, and on a standard AP X-ray, the humeral head is internally rotated and can look deceptively congruent. It's very misleading to the unwary clinician. You need a high index of suspicion.
What historical clue should immediately raise the alarm?
The mechanisms. You're looking for a massive forced internal rotation and adduction. So think epileptic fits, electric shock, or major trauma where the arm was fixed and twisted.
And the necessary imaging to confirm it.
You need 2 key views. On the AP view, you might see the light bulb sign, where the humeral head looks like a light bulb because of the fixed internal rotation. But the absolute essential view is the axial view. That clearly shows the posterior displacement. If it's chronic or locked, reduction is extremely difficult, often requiring open surgery. And post-reduction, the arm has to be immobilized in an external rotation brace to prevent redislocation and allow the posterior structures to heal.
Okay, finally, let's briefly touch on the non-traumatic types. Atraumatic multidirectional instability.
Right, AMBRI. This lacks a clear initial injury and is often linked to systemic hyperlaxity, which you can check with the Beighton score. On examination, you often find the sulcus sign, a visible dimple under the acromine when you apply downward traction, showing inferior instability.
And the treatment for AMBRI is fundamentally different from traumatic instability.
Completely different. Surgery is the last resort. The primary treatment is specialized physiotherapy focused on proprioception and muscular retraining. It's about retraining the muscles to fire precisely to dynamically stabilize the joint.
And what about the habitual or voluntary dislocator, the party trick person?
The textbook is very clear on this. These patients are often demonstrating a learned behavior. They must be counseled to stop doing it. Surgery, like capsular tightening, is highly ineffective and fails at a very high rate because the underlying issue is often neurological or psychological, not a simple mechanical one.
We transition now to the elbow, a structure that seems simple but is functionally critical, acting as both a hinge for flexion and extension and a pivot for pronation and supination.
The elbow is a very unforgiving joint. Any significant injury or stiffness severely impacts your ability to position your hand in space. The key anatomical anchor is to remember the crucial neurovascular structures. Median nerve, brachial artery, radial nerve, they all run anteriorly. But the most vulnerable structure is the ulnar nerve, which runs posteriorly in the cubital tunnel, right behind the medial epicondyle, the funny bone.
Looking at arthritis, let's compare how RA and OA present in the elbow.
In RA, the disease process is destructive and systemic. It often affects all the joint surfaces, including the radiocapitellar and proximal radial ulnar joints. This leads to painful and restricted flexion extension, but also severe restriction in pronation and supination.
So a global loss of function.
Yes. Treatment can involve a radial head excision, which specifically helps with pronation supination, or a total elbow arthroplasty for pain relief.
And OA has a different profile, doesn't it? Typically affecting middle-aged men in manual labor.
It does. OA is often post-traumatic or from high-load wear. The hallmark symptoms are pain, locking, and a distinct loss of terminal flexion and extension. They can't fully straighten or fully bend the arm, but crucially, the radiocapitellar joint is often spared initially, meaning pronation and supination are often relatively preserved compared to RA.
Given that OA affects high-activity patients, a replacement is a tough choice.
It is. Total elbow arthroplasty provides excellent pain relief, but the failure rate from loosening is significantly higher in high-demand patients. So, fusion or arthrodesis is sometimes reserved for heavy manual laborers, though it sacrifices a huge amount of function.
So what's a more common approach?
A more common approach is surgical debridement, the OK procedure, or similar lateral column procedures. The surgeon removes the osteophytes, the bone spurs, and any loose bodies that are physically blocking the joint from achieving full flexion and extension. The goal is to restore motion without committing to a replacement that might fail early.
Speaking of mechanical block, let's talk about loose bodies or joint mice.
These are fragments of cartilage or bone. They can be caused by OA or specific conditions like osteochondritis dissecans, which affects the capitellum in young people. The classic clinical presentation is sudden, sharp pain and locking of the joint. The patient often has to shake or manipulate their arm to unlock it.
And the treatment.
Usually arthroscopic clearance, go in with a camera and remove them.
Next, the very distinct presentation of olecranon bursitis.
This is a localized inflammation of the bursa over the pointy end of the elbow. It presents as a warm, red, fluid-filled, painful swelling. The immediate differential diagnosis has to be septic arthritis, which is a true emergency.
So how do you clinically exclude septic arthritis?
The anchor is movement. In bursitis, the pathology is superficial. It's external to the main joint capsule. Therefore, the central arc of movement flexion and extension between about 30 and 130 degrees is almost always possible and pain-free.
Whereas in septic arthritis,
In septic arthritis, the inflammation is within the joint capsule, causing a global, painful restriction of all movement. If infection is suspected, you have to aspirate the bursa for culture. Treatment is usually anti-inflammatories, or if it's clearly infected or chronic with calcific nodules, excision of the bursa.
our final elbow pathology is a critical one. Ulnar nerve compression or cubital tunnel syndrome.
Yes, the second most common nerve entrapment syndrome after carpal tunnel. The ulnar nerve gets compressed at various points, most commonly right in the fibro-osseous cubital tunnel, but also potentially more proximally by the arcade of Struthers, or distally as it passes between the two heads of the flexor carpi ulnaris muscle.
The subjective symptoms are pretty classic.
Tingling and numbness in the little finger and the ulnar half of the ring finger. On examination, a positive Tinel sign over the cubital tunnel is key. And with chronic severe compression, you start to see wasting and weakness of the intrinsic hand muscles. The first dorsal interosseous muscle is often wasted first.
And what's the most important physical sign of advanced motor involvement?
Froment sign. This tests the patient's ability to adduct the thumb, which is a strong ulnar nerve function. When they try to hold a piece of paper in a key pinch, the weakness in the ulnar-supplied adductor pollicis forces them to compensate by using the median-supplied flexor pollicis longus.
So what does that look like?
The result is that the distal phalanx of the thumb hyperflexes instead of remaining straight. It's a clear sign of severe ulnar motor neuropathy.
Treatment often starts conservatively.
Yes, often with night splints to prevent prolonged elbow flexion, which puts tension on the nerve. If motor weakness develops or if symptoms persist, surgery is indicated. Options range from a simple decompression to an anterior transposition where you actually move the nerve anteriorly away from the medial epicondyle.
We end with the hand, the ultimate tool of the upper limb. Function here is everything. When you're taking the history, you have to find out the exact deficit. Is it instability, loss of motion, pain, or pins and needles?
Exactly. And the functional examination must meticulously map out the three major nerves. The median nerve for sensation to the radial 3.5 digits and motor to the abductor pollicis brevis.
The O-shape test.
The O-shape test. The ulnar nerve for sensation to the ulnar 1.5 digits and motor to the interosseous spreading and closing the fingers, and the radial nerve, which powers the powerful wrist extensors. Loss of radial function gives you a wrist drop, which makes the hand functionally useless.
The text calls stiffness and swelling the archenemy of the hand. Why is swelling in the hand so devastating to long-term function?
Because swelling in the hand very quickly leads to fibrosis and irreversible contracture. The hand naturally settles into a position of comfort, wrists flexed, MCP joints extended, and IP joints flexed. In this position, the collateral ligaments of the MCP joints are slack. If you leave the hand immobilized there, they rapidly shorten, and the hand becomes permanently stiff and functionally useless.
So what's the counter strategy? The position of safety.
The Edinburgh position is the essential anchor here. This position actively prevents that ligament shortening. It's wrist extension, MCP joint flexion to about 70-90 degrees, and IP joint extension. By splinting the hand in this position, combined with elevation and early mobilization, you maximize the chance of preserving future function.
Let's discuss two critical ligament injuries. First, the thumb ulnar collateral ligament.
This is the stabilizer of the thumb's MCP joint, essential for a strong pinch grip. An acute rupture is called a skier's thumb. The critical clinical differentiation is the Steiner lesion.
What's that?
If you apply valgus stress and the joint opens up significantly, surgical repair is mandatory. That's because the adductor aponeurosis flips over and gets stuck between the torn ligament ends, physically blocking spontaneous healing. If you miss a Steiner lesion and don't operate, the patient gets a chronically unstable thumb, which we call gamekeeper's thumb.
And the stabilizer on the ulnar side of the wrist.
The triangular fibrocartilage complex, or TFCC. Injury causes ulnar-sided wrist pain, often with clicking or instability, especially with rotation and gripping. Peripheral tears near the blood supply can be repaired surgically, while central degenerative tears are typically treated with an arthroscopic debridement to smooth the torn edges.
Now we enter the unforgiving realm of hand infections, where a rapid diagnosis can prevent catastrophe. Let's start with the common ones.
Paronychia, an infection of the nail bed, is very common and usually managed with incision, drainage, and antibiotics. A felon is much more serious. That's an abscess confined within the fibrous vertical septae of the fingertip pulp.
And why is that so dangerous?
The intense pressure risks necrosis of the pulp and osteomyelitis of the distal phalanx. It requires urgent surgical incision and drainage, typically through a midline longitudinal approach, followed by 5E antibiotics.
But the single most dangerous infection is the flexor tendon sheath infection.
This is a surgical emergency. The flexor sheath is a tight, defined space. Pus rapidly increases the pressure, leading to thrombosis of the small vessels that feed the tendon. This results in necrosis and adherence of the tendon, a massive functional loss.
And some fingers are more dangerous than others.
Infection in the thumb, which is the radial bursa, or the little finger, the ulnar bursa, is particularly dangerous because those sheaths communicate directly with the deeper spaces in the forearm.
The surgical trainee must commit Cadaville's cardinal signs to memory. They mandate immediate surgical washout.
These 4 signs are the alarm bells. 1, the finger is held in slight flexion. 2, there is uniform fusiform swelling over the entire digit. 3, the tendon sheath is exquisitely tender to palpation. And 4, there is severe, often excruciating pain on passive extension of the finger.
The treatment is urgent and the technique is very specific.
It requires an urgent trip to the operating room for an open irrigation and washout. You make small incisions proximally and distally, and you insert a fine feeding tube into the sheath to lavage it thoroughly with saline and antibiotics. This immediately relieves the pressure and clears the pus, but it must be followed by an extended course of potent intravenous antibiotics. Any delay risks function, or even the digit itself.
Finally, let's wrap up with the systemic tragedy of rheumatoid arthritis in the hand. The ligament and bone destruction leads to predictable and severe deformities.
The classic deformities are landmarks.
Oh.
You have the boutonniere deformity, flexion of the PIP joint, and hyperextension of the DIP joint.
And the opposite of that.
And the opposite, the swan neck deformity, hyperextension of the PIP joint, and flexion of the DIP joint. You also see that classic pattern of radial drift of the wrist with a compensatory ulnar deviation of the MCP joints.
Oh, we also face the possibility of tendon rupture here.
Yes, Vaughan-Jackson syndrome describes the sequential rupture of the extensor tendons, typically starting at the little finger and moving radially. This happens because the inflamed joint often causes the distal ulna to subluxate dorsally, and the extensor tendons basically fray as they run over this sharp, bony prominence.
The management axiom for the RA hand, as described in the text, is really a masterpiece of pragmatic surgery. Start proximally, work distally, and alternate between motion-sacrificing and motion-sparing procedures.
The goals are always pain relief and functional restoration, but you're often prioritizing stability over a full range of motion. Procedures include syndectomy, distal ulna excision, arthrodesis, or fusion of the wrist to create a stable functional axis, and then joint replacements for the MCPs and IPs. The key is understanding that fusion provides a stable strut that is essential for key pinch and grip, even if it costs you motion.
We have certainly covered vast territory, interpreting the complexity of Baily and Love's Chapter 38. We've moved from the sophisticated rhythm of the scapulothoracic joint all the way down to the immediate, life-altering threat of a flexor tendon sheath infection.
And the common thread, as you said, is always rooted in anatomical reality, recognizing the mechanical consequence of reduced blood flow in the rotator cuff, the confined space of the cubital tunnel, or the unforgiving fascial septae of the hand.
And for you, the learner, success in the clinical environment really comes down to mastering those key differentiators.
Let's just reiterate those key anchors one last time. First, impingement versus tear. Can the patient move the arm actively after a pain-relieving injection? If they can, it's primarily tendinitis. If profound weakness persists, you have a mechanical failure, a tear.
Right.
Second, frozen shoulder versus calcific tendinitis. Is the loss of passive external rotation global? If yes, think adhesive capsulitis, a 1 to 2 year self-limiting course. If external rotation is largely spared but movement is restricted by sudden acute pain, think calcific tendinitis.
And the arthroplasty decision.
Anatomical versus reverse arthroplasty. The anatomical replacement demands an intact functional rotator cuff. The reverse is the mandatory choice when the cuff is deficient, as it mechanically compensates by recruiting the powerful deltoid.
And the hand emergency.
Always have Knevel's cardinal signs ready. Pain on passive extension of a uniformly swollen flexed finger demands immediate surgical washout, or you risk losing function entirely.
This deep dive gives you the map and the crucial decision points. But to truly master the territory of upper limb pathology and really secure that knowledge, you must open the book and walk the ground yourself.
And let me leave you with this final provocative thought, building on our discussion of advanced arthritis and the position of safety. We saw how crucial the Edinburgh position is for preventing ligament shortening and maintaining optimal biomechanical length. Now, given the complete destruction of ligaments and capsule in advanced rheumatoid arthritis, the primary goal of the surgeon often shifts from restoring motion to merely creating a stable, bone-fixed platform. How does this goal change the functional assessment, making even a fixed, fused wrist superior to an unstable, painful, mobile one? And how does the RTSA embody this very concept by trading anatomical motion for absolute stability against gravity?
Something critical to ponder as you review the source material. Thank you for sharing this dense source with us. We'll catch you next time for the next deep dive.